Pathology is the study of cells under a microscope. It is a critical field in healthcare, particularly in cancer diagnosis. However, a significant challenge in pathology is the inconsistency in reports and occasional disagreement between pathologists. This can lead to variations in cancer diagnosis and treatment, impacting patient care. To address this critical issue, one such groundbreaking approach is the integration of AI in pathology, which is pioneered by companies like PaigeAI. PaigeAI is a company in the field of digital diagnostics. They are using next-generation computational technology, machine learning, and artificial intelligence to revolutionize cancer diagnosis. PaigeAI's platform and AI applications, including the PaigeAI Prostate Suite and the Paige Breast Suite, have been instrumental in the pathology field. They provide actionable diagnostic insights that directly affect patient care. With their solutions, they have shown a remarkable 70% reduction in cancer detection errors and a substantial decrease in the time taken for diagnosis. As the first company to receive FDA approval for an AI application in pathology, PaigeAI has set a new standard in the field. Join me today as we talk to Dr. Moy, the CEO of PaigeAI. Thank you so much, Dr. Moy, for being here today. I really appreciate it. I'm very excited to have you.
Yeah, thanks so much for the invitation.
All right. So can you tell me, why do we need AI? AI has been everywhere, but why do we need AI to aid pathologists and oncologists in making diagnosis of cancer?
Well, that's a big question and a great question, of course, when it comes to innovation in cancer care and cancer diagnostics. I think, for us at Paige, we think about the world, I've spent a lot of time in lean manufacturing, right, or in Toyota Business Systems, these sort of things. And one of the earliest things you learn about lean is that you need to push as much information to the front of the process as possible, right? And I think in a lot of our healthcare system, I'm sure we'll get into this. The challenging thing for clinicians treating cancer patients is you don't have all the information. You really have a little bit of information, and you spend a lot of time as a detective trying to get to the bottom of, well, what's really the best course of treatment for this patient based on the information that I have. And we really believe that artificial intelligence and machine learning can very much provide more information to oncologists and to clinicians to treat those cancer patients, but also benefit pathologists in just the overwhelming workload that is now here, but that will be coming over the course of the next 20 to 25 years. And so it's that combination of things where the technology is available. We can provide more information for oncologists to better treat these patients using AI. We can also help and assist pathologists with their day-to-day work in ensuring that cancer doesn't get missed. It happens, that perhaps a Gleason grade 8 could be called a Gleason 6, and that radically changes the course of treatment for a prostate cancer patient. A Nottingham score that is, high mitotic counts versus low mitotic counts in a breast cancer patient. So these are all things that machine learning and AI can assist with as a tool. And we really believe that it's time for that transformation of the diagnosis itself, at the point of diagnosis, where the most information is gleaned from that slide, from that tumor, and provide that information back to the clinician and the oncologist who's treating that patient.
Yeah, I can't agree more. And that's why I'm very excited about this technology, because people, especially patients, don't know how we usually grade or score different types of cancer. You mentioned the Gleason grade and the score. It's very old age. So we take a part of the prostate through a needle, and then we put it on a slide, and then we send it to a pathologist. And that pathologist is a human being, whether they are tired, where they had a bad day, they had to look through the microscope and counts the number of nuclei or the shape of cells, and then they have to come up with a number. So exactly like you said, the glycine 6 is not equal to glycine 8. And that's what excites me. We have to come up with a standardized way of labeling different pathology slides.
Yeah, I think the standardization is really the key here. And, well, we'll just treat the US here for a second, right? In the United States, something when the numbers vary, but 70 to 75% of all cancer care is done in the community, right? And in concordance with that, about 70 to 75% of cancer diagnoses are actually made by generalists, right? So they're made by somebody in the community, whether that's at a large reference lab or community hospital, and maybe care is done in the community, and then a lot of times that care is then that patient transfers maybe to a Carmanos or maybe to a Memorial Sloan Kettering or to an MD Anderson, right? And then you get another round of care or something like that. And that's, the inefficiencies involved in all of that are really terrible, right? And so we believe in the technology exists today that by decentralizing this technology and making it available, really that democratization of this type of care allows community pathologists to do their jobs in a way that a subspecialist would be able to do it, but then perhaps arm that community oncologist with better options and better information. So maybe that patient doesn't have to travel. Maybe that first line of cancer treatment is really effective. And there's enough information about biomarkers, about a lot of different things that enables that patient to stay in place. And then lastly, and I'm sure we'll get into this too, because I think it's really important, that there's information about whether that patient qualifies for clinical trial. Right. I mean, we know the approval for
Exactly.
clinical trials in the United States is so low. I can't remember off the top of my head, at least less than 10%. And the ability for the oncologist really to challenge is what are the inclusion and exclusion criteria of all the hundreds of trials that are out there for each type of tumor type. So again, for us, it's really that standardization. Can we get everybody, no matter where you are in the United States, that if you have a biopsy taken, I won't name a place in the country, but somewhere in the country, and that biopsy is sent to a local hospital, and that local pathologist who is a generalist and sees all different types of cancers, that AI enables them to perform at that level. And actually, in our FDA study, Ripon, we showed that actually the sensitivity for generalist pathologists in detecting cancer using AI tool approached the level of the subspecialist, right? The GU, subspecialist. And so that's really what gets us excited. It's about helping to standardize and provide a better course of care for that cancer patient, no matter where you live. And that's also really important.
And you are touching on many pain points that I experience every day. People underestimate this. You talked about the access of care, and this is something happens for those people who are listening. Like, this is 100% true. I work in downtown Detroit, and we get lots of patients from the periphery of Michigan, and we request their pathology slides because the interpretation from their pathologist could be very different from the interpretation of subspecialized pathologists in academic center. And that's what makes me excited about AI. Anyways,
Yeah.
I will let you do the talking here.
Well, on that point too, though, I don't know again what the percentages are, but not everybody can afford to move to that specialized care center,
Exactly.
right? And in fact, I would argue maybe very few people can. And
Yeah.
so what ends up happening in the community is that community oncologist does the best they can with the information they have. The patient doesn't move on. The patient may just get chemo or radiation or whatever course of treatment they best think. But who knows, right? There's been some studies, been a lot of literature out there on this topic. We work very closely with Memorial Sloan Kettering. We've heard that anywhere between 5 to 10% of the time, those MSK pathologists change the diagnosis of the initial pathology diagnosis depending on the cancer type. There was an article in the Wall Street Journal about 3 months ago now by a hematologist, hemopath at the University of Miami, and their experience had been up to 20% of the diagnosis that came in were not right, or they were or either reclassified or so it's a huge range and spectrum, that initial diagnosis, and it makes such a huge impact on care, because it's not enough just to know, okay, there's cancer here. I mean, obviously you need to know all the TNM and you need to understand the the part of the challenge is even it goes after, if you get a resection, lymph node involvement or prediction of lymph node involvement and whether this is regional disease or metastatic disease. So again, we touch on this topic, but technology exists today and we don't have to do this the same way it was done in 1910. Right? Which is,
100%. That's how we're doing it. The same way it was done 1910. I 100% agree.
it's exactly true. It's a terrible joke, but the joke is that, if a pathologist from 1900 walked into a modern pathology lab today, what would they say? What would they think? Well, they would say, hey, give me a seat. I'll sit down and start reading cases because it's exactly the same as it
Yes,
was.
yes. Thank you.
So,
Thank you. Yes.
yeah.
I can't agree more. Okay, so but what about beyond what the human eye can see? For those who
Yeah.
are unfamiliar, can you explain what is the concept of pathomics and how
Oh, great.
PaigeAI is
Yeah.
leveraging it in cancer pathology?
Yeah, this is where it really gets to me. I think about transforming cancer diagnostics, certainly standardizing, some of these things that may be more subjective, certainly ensuring the objective, is there cancer or not? That's important. But then we really start to get into precision medicine, precision oncology, and all of again, the information that the medical oncologist is really going to need to care for that patient the best, to give the right course of treatment. I think the challenge, and I'd love your perspective on this for oncologists now, is over the past 20 years, the explosion of precision medicine and trying to keep up with, which drug for which disease type in which line with which biomarker, right? It's tough, right? It's and in what
100%.
combination, right? Is this with chemos, without, trying to remember all those things is challenging. And I think, there was a study done in JAMA, it's about a year and a half old now, and it said about of 1,000 patients who would be eligible for precision medicine and non-small cell lung cancer, right? So
Mhm,
either a
mhm.
RET or an EGFR mutation or an ALK mutation or ROS mutation, only about 33% of those patients actually get a precision medicine. So this is 1,000 patients who are eligible. They have one of those, onco drivers that would be eligible for precision medicine. Only about 30% of them. And so why is that? And it's sort of the attrition table goes from, well, they never got tested, right? That's a big part of it. Um,
Mhm.
Doctor couldn't know, not enough time to test, so they just went ahead and started on a chemo regimen, a platinum regimen, or whatever. So, and then that was too late. Affordability, right? There was, financial toxicity issues. There was, drug, payer issues, whatever. So all these things, trite down, and only a small portion of the patients that could have benefited from a really good precision agent didn't get it, right? And so those are the things we also want to try to fix. And so as a great example of that, we said, well, how can you do that, Andy? Well, how do you fix that? Well, AI can help this. And this is where it starts to, people really need to understand the
Exactly.
power of AI. At the end of the day, what artificial intelligence is really good, especially with what we do in computer vision and even things like GPT-4. In computer vision, it's very, very good at pattern matching, right? Being able to find the very, very subtle patterns in tons of data. And a single glass slide, by the way, just so when you digitize it, it's about 2 gigabytes of data, right? It's a lot of data on a single glass slide in a 40x scan. And so you think about, can AI discern the various nuances of the morphology for a patient who perhaps has an EGFR mutation, as an example, right? EGFR, certainly something most non-small cell lung cancer patients should get tested for, because there's other drugs for the various variants that go along with that. But we've, proven, and we've published actually on EGFR mutation status, that you can find those patients just on the H&E slide on the original diagnosis of non-small. You can call cancer
Oh,
there.
wow.
You can also predict whether that patient, with about 90% sensitivity, whether that patient is going to have an EGFR mutation. And there's no excess cost to that. I mean, you have to run the AI, so there's cost in the cloud, but you're not scraping that tissue, you're not sending it for next generation sequencing, you're not sending it for a large panel, you're not waiting 5 weeks. At the moment you scan and digitize that slide, the AI can run it in 20 seconds and tell you if there's a biomarker there. And so
Unbelievable.
the future on this, particularly for oncologists, is why would I wait? I mean, certainly you need to do the concordance, and we get all those. But why wait? If there's a 90% chance that patient's EGFR mutation, why wouldn't I start that patient on that therapy now? If I can, right? And so I think those are really the interesting things. You can predict a lot of those type of biomarkers. Maybe one last example. We have an algorithm that is clinically available today, and it's from microsatellite instability for colon cancer patients, right? So, the mismatch repair genes that control, or DNA repair issues in colon cancer patients. NCCN guidelines, you should test for these patients, right? You should test for them, A, to determine whether there's, microsatellite instability, but B, for any potential hereditary Lynch syndrome, type things, right?
Yeah.
You think about microsatellite instability today. In order to assess that, it's 4 immunohistochemistry stains. So you're waiting on that. The pathologist has to assess them, or you can do it with next generation sequencing. You can also do it with PCR. This takes a lot of time. Again, our algorithm, about 95% concordant to next generation sequencing or MMR testing to determine whether that patient has microsatellite instability in the colon cancer specimen. And so you can, very quickly understand that using AI as a way to predict biomarker status can A, get the patients quicker to treatment, B, enable cost savings to the system that ultimately, might ripple down and provide some relief to the patient. But this is really where we think the future is. We're excited about, where biomarkers go on AI in tissue. And then maybe one last thing, there's also the ability for AI to predict patterns in the tissue that's completely novel. So is an example that, can you predict whether a patient will respond to an immune checkpoint inhibitor like Keytruda, right?
Yeah.
Just from the slide. Today the biomarker that most people use is PD-L1 status, which is an immunohistochemistry stain. You also think about tumor mutational burden, which there's a lot of different ways to assess that. We've also published on that we can predict response to Keytruda better than both of those biomarkers just from the
Unbelievable.
AI, right? And so there's, of course, this takes time and effort to sort of assess clinically, but the AIs can do this. I think to your point, a lot of people just say the same thing. You say, well, that really, like, is
Yeah, I'm surprised.
Can do it. It can do it. Not everything, not every biomarker, not every genomic mutation manifests in the morphology, but this really goes to underlying biology of what we believe is that, because there's so much information just in the H&E slide scanned at 40x, that you can pick up patterns, and discern patterns, and the AI can do that help predict what that patient has or what they might respond to.
Oh wow, this is very exciting because so for people who are listening, how it works, cancer therapy change a lot. Going back to the first point, it's not only chemotherapy. We have tons of treatments that targets each specific cancer depending on what type of mutation that cancer have, right? So how it goes, let me give you an example and why this is important. So clinical example, I saw a patient in the hospital who was diagnosed with lung cancer. And if I send this pathology, or if I send the sample to the pathologist is going to tell me, is it lung cancer or no? Then I have to take this sample and send it to a different company. So there is a third party here that's going to tell me, well, what type of receptor, what type of gene mutation this cancer have. So depending on that, you can choose a treatment other than chemotherapy. So, and I can't do that when the patient is in the hospital because because the test is not covered by insurance when the patient is hospitalized.
Right. Yeah.
So that's another thing. That patient's tests were delayed by a couple of weeks until he left the hospital. Now I'm thinking about this, and you don't need all the markers. If the most common markers are there, if the pathologist can tell me this is a lung cancer with EGFR mutation, I can immediately start the chemo authorization or the treatment authorization for the specific targets for the EGFR. This is mind blowing.
Yeah. Well, and you get into now probably the most frustrating aspect of our healthcare system, right? Which is the payer, the prior auth system. You're talking about the 14-day rule, which is this very arcane sort of payment problem that Medicare,
Mm-hmm.
if you're an inpatient, yeah. So it really, this is one of the challenges with new technology adoption in healthcare broadly, because I think about it in three legs of a stool, right? The first leg is that whatever new technology you're introducing, it needs to be better for patient care. I think that's the
Mm-hmm.
bar, no matter what. And I think, your physician colleagues, always there's a range of what they're willing to accept, right? Ranging from, I want to see 10 prospective randomized clinical trials all published in the New England Journal of Medicine, all the way down to, well, the sales rep showed up and that he's good enough. It looks good. So I think there's a wide range in what people are sort of willing to accept. The second is, how much does this affect my current way of working, my current workflow today? And for pathologists to move to digital, it is a new way of working. It's not the way they were trained. It's not the way, especially if you're an older pathologist and you spent 40 years looking down the barrel of a microscope. It's not what they were trained to do. So it definitely changes that. And then of course the last bit is always the economic piece, right? How much does this cost? Who's going to pay for it? Right? How are payers going to pay? Is this going to reduce my costs overall? Is this going to make me more efficient, et cetera? Right? And so I think if you have something that is very clearly better for the patient, doesn't move workflow too badly, but also maybe makes money for the hospital, then you have probably a home run, right? Very quickly, somebody will say, okay, this is, and you move in. But that's very, 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 very few, I think, new technologies. And I think AI is one of those. I mean, I think AI everyone's very excited about. And even for admin burden, right? I don't know if you've messed around with GPT-4 or
A
like something
lot.
like DAX, right? Like we're just, can it assess, can it take my clinical notes and give a summary? Or can it, review these, 10 new articles and give me a summary? Like you can do those things, right? But in your current clinical workflow, how does it fit? Is it safe? Is it safe for patients? I'm sure there's a governing board thinking about all these things. So my point is, yeah, the health, the payer always impacts everything in the United States, and impacts the ability for hospitals, health systems, doctors to get access to this new technology, because it causes issues with the patient paying or the hospital paying or whatever the case may be.
Thank you so much for pointing on that, because like that's what makes innovation in healthcare different than innovation in any other.
Yeah.
Because first you have to figure
Sure.
out who is going to pay for it, and like it's healthcare is not B2C. Healthcare is
That's
B2B,
right.
and you have to figure out the second B. That's it.
Yeah, and the other challenge, again, just speaking about the United States, is that particularly coming out of COVID, we talk about community hospitals. Most of those community hospitals are break even or negative margin. Again, my PhD is in health economics, right? You think hard about how these hospitals and health systems make money. They don't get the same payer relationships. They don't get paid as much in a lot of ways. A lot of that, people don't realize. You're a small community health system, what you negotiate with the payer and the rates you get paid very different. And if you're, a big UPMC or Mayo Clinic, or, that you have a ton of leverage against the payer. And so a lot of those hospitals and health systems, again, where our technology probably would benefit the most, are in those community health systems, but they're getting pounded by the payer. They're losing patients to larger urban areas or whatever the case is, and they're working at negative margins. And so they're probably going to be
Gotcha.
the last area, no matter what the technology is, to adopt a new technology. And so you have to sort of start somewhere. I mean, what we've found is certainly the large academic medical centers, Memorial Sloan Kettering, University of Miami, University of Louisville, Yale. I mean, these sort of places have incentive to bring in new technologies, use them, study them, publish on them, and have some economic cushion to be able to absorb some of those costs, right? And they can do that in a certain way. They have some margin to do that. It's not so, again, in the community, and I think that's really going to be one of the big challenges here, over the next 5 to 10 years, is how do we really ensure a lot of these new technologies are hitting the places it'll impact patients the most.
Gotcha.
Yeah,
How is PaigeAI technology positioned within the healthcare reimbursement model? Like,
sure.
are there any
Yeah.
financial incentives for institutions to adopt the technology?
Yeah. maybe just a real quick on, we didn't talk too much. So we provide software that allows, again, the pathologist to review these slides digitally so they can look at that. That's an FDA approved product. And then we have these applications that stack on. So AI application, our first FDA approved and still the only FDA approved product is for prostate. So you can detect cancer better. It also does Gleason grading, and it automates that. It automates the tumor percentage in the area. We have products for breast cancer, again, for detection, for grading, for mitotic counting. We got an FDA breakthrough on a product for lymph node, and for
Oh,
that
wow.
particular dilemma is, as you know, is looking for Mets, in the sentinel lymph nodes on breast cancer, or any of the axillary clearance, lymph nodes, and finding Mets, and so we have breakthrough status on that. So these applications, each one, certainly we're a company, we're a startup company, and so we are a for-profit company, and we have investors, and so we're like technology, and so we provide a quote to the hospital or the health system, and they determine whether they can pay that amount and move on. However, to the point you're asking, how do we work in the health? Ultimately, I view a world where the payer certainly sees value to their members to have that pathologist use this technology, up front. As an example of that, we're hopefully first part of next year, we've been part of a 2-year prospective study in the UK to study the health economic benefit of using Paige Prostate in the NHS. Of course, in these countries like Canada, right, where it's sort of single payer, you get a bit more innovation. You actually see that the health system is more incented, because it's all one payer, to understand how these new technologies are adopted, right? So in the UK, I would argue they're very much ahead of the US in adoption of technology, because they funded it. They said, hey, we need to study it. We're going to go through this process, and we're part of that. And so we expect probably in early 2024, mid 2024, the UK to come out with some number that says, hey, here's what we're going to pay for the use of Paige Prostate, because we see the value downstream, right? As an example, that Gleason grade 8 patient is a Gleason 6, and so instead of getting a radical prostatectomy, that patient got nothing, watchful waiting, and just
Yeah,
active.
exactly.
So I do envision a world where the use of AI for diagnosis gets reimbursed, and so as a hospital or health system, you can bill a code. You would pay us, right? The hospital health system would pay us as a technology provider, and you would bill a code and get reimbursed by the payer, because there's value to the patients downstream. We're a few years away probably from that. But in the US too, maybe one last note here on that is that the AMA and CMS recognize that pathology probably needs to move digital. Just like radiology moved digital, and the medical records move digital, and and cardiology move digital. And so there are some new codes out. They don't get paid, don't get covered, but just for the digitization of the glass slide, which is a good step forward. And hopefully some reimbursement comes from that. So if the hospitals, any hospital or health system in the US says, okay, hey, I just want to digitize all my glass slides, they can do that and they'll get paid for it. And then hopefully there will be AI reimbursement on top that will help also drive adoption. So I think, yeah, ultimately you have people who are really excited about the technology. They're willing to pay for it because they see the benefit to patients. And I think the rest of the world will follow when some payment does come that way.
Oh yeah, I think like it's beyond the patient. Like if you think about it, what PaigeAI is providing, it's improving physician well-being by it's making their work much faster. And I was talking to this with Dr. Karim Hanna on previous episodes. He's a physician with background in clinical informatics. Like any hospital system, to retain good number of physicians, they should improve their systems, because recruiting a physician on average, it costs $30,000. So it is much cheaper to improve your system and retain your physicians than having a high turnover.
Yeah, yeah. I mean, to talk about that for a second, I think, and I'm not exactly sure, I'm sure oncology is the same way, but pathology, they're predicting, 5,000, a gap of 5,000 pathologists, by, I want to say the mid 2030s, right? So, the number of cancer diagnoses will double in 20 years. But the problem
Oh
is
yeah,
pathologists coming out of residency are in medical school are dropping every year.
100%.
And so it's interesting because a lot of the customers we work with, particularly academic medical centers, have this issue. They're having a hard time recruiting pathologists.
Yes,
And
yes.
in a traditional way for pathologists, it's always been you have to be here, right? And wherever we are, you must come to this lab, you must have an office in this lab, and you must sit in this hospital, wherever that lab is. And the radiologists years ago have been untethered from that, right? The radiologists, they're certainly in the town, but maybe not always in the hospital. They can read
They were
cases
from
anywhere.
Italy.
Oh yeah, sure, right, exactly. They're sitting around, and sitting when they want. So I think you're starting to see a world too, with pathologists. If you want to attract, number one, you want to attract pathologists to your health system, you have to have a digital AI strategy, I think, because number one, they don't want to all come live in the town that you happen to be in. And number two, I think the other interesting thing, Ruben, is that the pathologists or the students coming out of residency or certainly out of medical school now, they all grew up with the iPhone, right? They're
100%. Yes,
digital
exactly.
kids, right? In a lot of ways, I'm older than I look, so I'm not. But like you grow up, now there's a generation of doctors coming into the workforce who are like, hey, I use GPT-4 every day. I've got my iPhone. Why would I sit here and stare at glass slides all day?
Yeah.
That doesn't make a lot of sense to me. And so I think too, that's another big tailwind of adoption. We certainly think that will drive this, but the physician shortage issue is real, right? I'm sure you guys feel that it's there's just too many patients. Yeah,
100%. 1,000,000
yeah,
percent.
yeah. And so hopefully that will drive, that new technologies are not bad. They're not taking people's jobs. The reality is there's not enough people to fill these jobs, right? So that's the challenge that we're trying to solve as well.
Oh yeah, I think there will be two group of physicians: physicians who use AI, physicians who don't use AI. So those who
Mm,
don't use AI, they will just be far behind. So those who use AI, they'll augment their skills. They will increase the number of patients they see, and they will also deliver care more efficiently. And it's not
yeah.
only the shortage of number of physicians. I'm very excited about this. It's we are seeing younger and younger people diagnosed with cancer, and there are tons
Yeah.
of study out
Yeah.
there come from this.
Yeah. Yeah. That's interesting too, right? I don't know. I've seen those trends too, and I'm not exactly sure what's driving that. But I think too, that's another big macro trend, right? Is
Mhm.
that consumers, like 10 15 years ago, and even older generation, my mom, for example, like she goes to the doctor, whatever the doctor says, like that's it, like just whatever the doctor said, I'm doing. I think now there's a generation of people, of patients, and to your point, younger patients who want to be very involved in their care, who spend a lot of
Mhm.
time on Dr. Used to be Dr. Google, right? Now it's Dr. GPT-4, but I don't know
Exactly.
what's better. I don't know what you think is better. You treat these patients, but they want to be involved. They want to understand the ins and outs, and they probably want to ask those hard questions. That we think are worth asking. Is, hey, was that diagnosis initially made? Could there have been something wrong? Could there be something in it that wasn't accurate? Is it worth getting a second opinion? Was AI used to address it? And I think we'll also see patients driving a lot of that adoption too. To your point.
Yeah, yeah, 100% I agree. You touch base a bit on the accuracy. Maybe we can expand more on this.
Yeah.
And so for those who are listening, like what measures do PaigeAI take to make sure that the results it's providing, it's accurate,
Yeah.
it's reliable?
Yeah.
What are you guys doing?
Yeah, and another great question, right? And this also is two things. I think the first is that, generally, if you think about your audience, how much they sort of know about laboratory medicine in general, right? So I've been spent 20 years in laboratory medicine. Every laboratory test, maybe it's FDA cleared, probably not. It was probably, put in place as a laboratory developed test, validated in the lab. COVID is a great example. All the COVID testing that got
Yes.
done, all of that was LET under emergency use authorization, of course, with the FDA, but those are PCR tests. You have some sort of like, I know with this test, here's a control, here's what we know the results should be. We run a bunch of samples, we validate that test. Okay, 95%, sensitivity, 90% specificity, positive predictive, negative predictive. So there are these certain assessments of every laboratory test that every laboratory and every laboratory medical director signs off on. And they're not all perfect. There's no such thing as 100% sensitivity, 100% specificity, 100% positive, no false positives, no false negatives, ever, right, in any sort of laboratory test. And so we view AI in very much a similar way. I mean, AI is not perfect. And so the clinical validations are important. We take a lot of strides. Number one, we're fortunate to have a lot of data from a really great cancer center in New York and Memorial Sloan Kettering. The data that we have from Memorial Sloan is actually multi-center, because like we talked about earlier, about 30% of these patients actually came from somewhere else. So the slides were produced somewhere else. So we have tons of sort of diversity. It's like 800 institutions in 50 countries. And so there's tons of diversity in actually the data set. So the data set enables us to build AI that's generalizable, that's reproducible. And then when it gets into clinic, it can be validated quickly, and there you go. However, my opinion, it's not enough, right? I think certainly the FDA has a part to play here going forward in ensuring that not only that the AI is performing and doing what it should do in very stringent studies, but the hospitals and health systems and doctors like you can trust those results, because I think that's really what is most important. Understand, like GPT, understanding the limitations, right? So at 98, for example, I'll Paige Prostate, 99% sensitive, right? Well, there's still 1% not sensitive,
Yes,
right? There's still,
yes.
it does give some false positives, right? Not many, but it happens, right? So those are the kind of things I think too, people need to understand that AI is not perfect, right? But like any method to get to an answer, any tool, it has its limitations. GPT-4 has its limitations, the hallucinations, and you can manage that in some way. And now they're giving you tools to help manage the hallucinations and things like that. But ultimately, that's the way we think about it. So for me, number one, it's about the data set. We work very hard to ensure that data set is diverse enough to limit the bias as much as humanly possible, right? Number two, the way we create the AI eliminates as much human interaction as possible. It's really about the pattern you're looking for in the data set itself. And I think we've shown that. I mean, we have the only FDA-approved product. It's been 2 years. No one's been able to follow. So I think that really helps strengthen. And I think the future of AI becomes now these really large foundation models, right? So like GPT-4, we're working with Microsoft. We announced a couple of months ago where we're building the world's largest, computer vision pathology model that we think will be pan cancer, right? So basically look across all tumor types, even the rare variants, the things that you don't see very often, the pathologists don't see very often, and help provide information about it. And then also probably provide more information about the biomarkers and things like that. So we've done a preprint on our foundation model. And so we're excited about that feature. So, again, it's a long-winded answer, but to answer your question, it's sort of, it's inherent on the companies who are providing this technology, to do it right. I think there's some companies that aren't. I mean, if I'm being very honest. And secondly, I think it's up to the clinicians, the hospital's health system, to ensure the validations are very strong, right? They need to really feel comfortable that tool in the workflow works as expected. And then lastly, I think it's going to be incumbent on the FDA and regulators to ensure that these are safe and reliable for clinical use.
No, I completely agree with you. And I just want to emphasize one point, that every test, it has its limitations. Let's take the most basic test, complete blood counts. I work in an inpatient and outpatient setting. Inpatients, we test complete blood count, which looks at the hemoglobin, red blood cell, white blood cell, etc., every single day. And we look at the trend. And I have tons of patients who their hemoglobin level was like around 10, 10.5, and then suddenly it's 7. The first thing I do is repeat the test, because I know that there is high likelihood that this might be wrong. And that's where the human supervision is important. Every test, every single test has its own limitations.
Yeah, you got it, right? I think this is to maybe address those people who feel like AI will take the jobs of the doctors, and are like, no, right? Because ultimately you need to have the knowledge, the experience, just as you said, to be able to sort of weed through some of these results and go, oh, well, hang on, now, what are we looking at, right? What does the trend say? All the things about that patient, right? In that particular case, is there any anemia, any jaundice? I mean, is there anything going on with that patient that would make you think that's a real test result? No, right? So let's repeat it and see
Exactly.
what's there. So I think too, we very much believe the same thing, that AI is a tool, just like any tool you're going to use to get to the right answer, or get to a better answer based on the information you have.
Gotcha. Okay, so for the sake of time, I want to move. I want to shift gears, and I want to really understand more about you. You have an amazing background. You have a PhD. You've done a lot. So, could you share your journey through the intersection of AI and healthcare? Like, what inspired you to focus on cancer pathology? How did you
Yeah,
transition from science to entrepreneurship? Like, what's the secret sauce?
well, I've spent, so my background very quickly. So I spent 8 years flying airplanes for the Navy. I always wanted to serve. I always wanted to be part of the healthcare, system. And I just kind of, honestly, between you and I kind of fell into diagnostics. I was fortunate enough to be hired by a very veteran friendly, company, and started on this journey, and sort of very early realized, like, some of the things we've already realized, which is this really the best we can do from a diagnostic
Yes.
perspective? And working with new technologies. I was very early on. I was working with a guy, famous oncologist, Dr. Dan Van Hoff, and he had this theory 20 years ago that you could do some genomic profiling and maybe give some drugs that are off label that are impacted. 20 years ago, oncologists were like, get out of here. Like, you're crazy. Like, no one, I'm not testing for all these IHCs and microarray and all these kind of things. But now, as we talked about, precision medicine is critical. You need to understand whether these patients have these biomarkers. So, really bringing new technologies to the clinic has been very fulfilling for me and rewarding. And what I'm most excited about Paige was, it's kind of this collision between a lot of things, as we've talked about for the last 40 minutes. Is it's diagnosis and diagnostics, but it's cancer and the journey that the cancer patient goes through and how the oncologist thinks about their treatment. It's data, right? It's taking tons of data in a way that now provides better information for those cancer patients and those doctors who are treating them. And it's workflow, and it's costs as well. It's health economics. So it's really, to me, this interesting collision of all of these, maybe not separate pillars, but a lot of different pillars in the way healthcare technology is adopted, kind of all in one place. And I think for oncologists who treat these patients every day, like you, or the pathologists who have to provide information to those oncologists, this is real. This transition is happening, but at the same time, you have to continue to treat patients and make diagnosis. So it's an interesting time to be, part of this journey. And I think, we're well positioned. It's not there yet. I mean, if I had to really guess, it's 5 or 10 years before every cancer patient, or at least a large majority of cancer patients, are getting the benefit of an AI, assisted diagnosis with some AI assisted biomarkers and treatment predictions, et cetera. But you have to start somewhere, right? And you can't do it all at once, but you have to start somewhere.
I love it. I love it.
Yep.
So, bringing any technology into healthcare is not easy. What
Yeah.
were the biggest challenges you faced when you were trying to integrate AI with pathology?
Yeah, I think the biggest challenge is you have to start somewhere, but you have to start somewhere. It's digital. But the interesting thing about digital pathology, we didn't come up with it, obviously. I mean, we're just trying to drive the AI side of it. It's been a change that's been happening over 20 years. And I think the change management piece is way harder than people recognize in healthcare. I think if you're a big bank, and the CEO of that bank says, hey, we're going to use GPT-4 for our chat bots, and this is how we're going to do customer experience. And here's a project manager, and he's going to run it, and we've already bought it, and here we go. right? That can happen. Like that can happen. There can be a 6-month change transition, a huge bank, 100,000 people can all now figure out how they're going to live in that world, right? That's not the case in healthcare, right? Number one, almost all healthcare
100%.
is almost all healthcare is local, right? I mean, it's what happens at Carmanos or in Detroit are very different than what they want to do in Miami or in Texas or in California
Yes, that's
or
true.
in Canada or in Europe, right? They're very, 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 very different. And so you have to manage through all the local populations. Everybody feels like their local population, the community serves is very different, right? So
Hmm.
that's the challenge. So I think it's really the daunting effort of where to start. What's the limit of the challenge, but where to start. And so we really started with, again, can we get people to believe in the results of something like Paige Prostate in such a way where they'll start to adopt it? I think if you bring too much too fast into the healthcare system too, you might get a complete no. We're not using any
Yeah,
of that. Right?
yeah,
That's too scary. You look at liquid biopsy. Right now, what's happening with Grail is over the past 9 months, most of the oncology community, even the general practitioner community, have said, "Hey, no, we don't know.
yeah.
We don't know what right? And until there's giant studies and, it's really maybe hurt to some degree the adoption of liquid biopsy because too much too fast, I think, in a lot of ways,
Yes,
right? For the healthcare
yeah.
product. So you have to provide, the clinical evidence has to be there, the FDA approvals, we've gone through that process. But now it's really, it's just education, education of physicians. Podcasts like yours is a great venue to do that. So the more people we can touch and sort of get the message out that, hey, the technology exists today, it's safe, it's effective, you can use it, and it provides efficiencies in care and better care for cancer patients. It's really the message we're trying to deliver.
100% I agree. I think in 5 years or 10 years, like not using AI should be crime, whether it's oncology, whether it's in pathology. With the amount of data, it's scary. I don't think a human brain can tolerate, can ingest, can digest all this data.
Yeah, that's right. That's really the challenge is, at some point you need to use these tools just like anything else. If you're not using that
Yeah.
specific methodology or whatever, that's standard of care. That's really what we need to get to is standard of care. That AI is your friend in the practice of medicine and in the diagnosis and whatever you're doing, and it can be standard of care to help patients on their journey.
We're approaching the end. One more question, and I just want to
Sure.
understand what is your approach when you hire people? What are the things that you look for when you try to build teams?
you know, for sort of your health tech innovators out there, one of the biggest challenges in healthcare and tech is that computer engineers, software engineers, AI scientists are not doctors typically, right? They're not clinicians, they're not pathologists, and and they're not PhDs, and they're not clinical trial experts, and I mean, so we've seen this over the last 10 years, right? Every big technology company's had a shot at this, Google Health and we're just going to solve it. We're the smartest people on earth. We'll just solve this healthcare problem. And then they had to shut down. Because it's like, at the end of the day, about 80% of our team are technical people. We're a software company at our heart. We're an AI deep science company. So it's software engineers, AI engineers, product managers, AI scientists. But yet I have to balance that with clinical people who can help guide the product development of those things. And so we really look for people. I mean, obviously they have to know their field, they have to know what they're doing, they have to understand the content, but they have to be cross-functional, right? They really have to be
Hmm.
able to understand, okay, I know how to build this technology, but can I work with Dr. David Klimstra, who has got 40 years of pathology experience, and he's going to guide me in this thing, right? So I understand how best to position it. So I think those are really soft skills. I think most of the time you have to hire for the hard skills. You have to know how to code and know the AI science and all those kind of things. But the soft skills are so important because if you're not able to work cross-functionally in a health tech company, you're not going to survive, right? The products aren't going to hit the mark. The users, at the end of the day, the end users are the oncologists, the pathologists, the doctors, the nurses, the lab techs, right? These are not technical people necessarily. And so you have to be able to translate really good technology to what they need. And there's a lot of cross-functional work that happens internally in our product development, et cetera. So that's, I think, the biggest thing we're looking for is do you have some emotional intelligence? Can you work cross-functionally? Can you manage that? That's really important.
Amazing. Well,
Yeah.
thank you so much. I really, really appreciate your time. I don't want to take more of your time, and you enlightened me. Like I was reading a lot about PaigeAI, but like the things that you mentioned today, like didn't cross my mind, and I'm very excited to see.
Yeah.
Hopefully, PaigeAI is implemented in my institution as well.
Very good. No, I appreciate the time. And again, the more we can sort of get this message out, the better. So appreciate the invitation.
Thank you so much.